Well, good afternoon, and again, thank you very much for joining us. As we go through this event, we'd like to invite questions, so please do use the chat box and pop questions as we go through. Would like your participation. So, good afternoon. I'm Shane from Space Law Healthcare and a concept advisor. And today's session is about sharing some insights with our guest panel, mainly focused on outpatient transformation. Before we kick into the discussion, just wanted to give a brief introduction to who Space Law are. So Space are the creators of architectural space-defining furniture, the blend of California cool and London design. And we've learned from our integration and working with some of the world's successful global organizations such as Google, Pfizer, Roche Diagnostics, across sectors, how we can help them achieve their organizational goals, whether that may be adapting to hybrid working or attracting and retaining top talent. And it's on this journey we've developed and co-created some core products for these organizations, and ultimately has led to our work within healthcare, mainly focused around using some of our individual pods and booths for telemedicine and focusing on virtual consultations using our modular private booths for focusing on telehealth. So today's discussion, we wanted to bring in and share some of our insights along with our guest panel to how we can help you continue this outpatient transformation throughout 2024. So the topic is outpatient revolution or rebellion, debunking the controversies and conquering transformation challenges in 2024. So the idea of this was to really look at some of the challenges we've all been facing with outpatient transformation and how we need to ensure those transformations are made to avoid patients continuing to be dissatisfied with their services. And so using the experiences from the panel, looking at some of those challenges and solutions we can implement throughout next year to really boost the transformation. So I just wanted to introduce the panel. So maybe Scott, thank you very much for joining. If you want to kick off.
Yeah, hi, thank you, Shane. So my name's Scott Deacon. I'm a consultant orthodontist by background, so I straighten teeth some of the time. And then the rest of the time I'm doing other things like being clinical director of outpatients and also a lead role in continuous improvement in my trust. I suppose my journey on this started some years ago when I was asked before the pandemic to look at how a particular hospital in our trust was answering its telephones, and we ran a project called Take Phonership, which then became part of the customer service strategy for the trust to try and improve the simple thing of answering a telephone, which I'm sure is a problem that most of us face at this stage now in most of our outpatient settings for various different reasons that are slightly different from they were before the pandemic, but still very relevant. And at the moment, I'm very much involved in the delivery of a Doctor, which is our patient engagement platform, and trying with my colleagues in digital services to digitize the whole patient journey from referral through to discharge, particularly in the outpatient setting, which is one of my sort of pet subjects, I suppose you might call it, where we're trying to ensure that patients have a smooth end-to-end kind of digital process, which will help with communicating with them effectively. Going forward. So that's kind of where I'm at the moment. So thank you, Shane, for your invite.
Good, thank you, Scott. Appreciate you joining. Look forward to your insights. Alex Kimber.
Yeah, thanks, Shane. Hi, I'm Alex Kimber. I'm the Trust Outpatient Manager at University Hospital Southampton. I've been in the NHS for about 15 years in a variety of roles, mainly based in digital backgrounds and digital project management. As my outpatient journey started around about after the start of the pandemic, really, where previously the main focus from our trust point of view was deemed to be out inpatients and theatres, and then outpatients become the number one factor. And we've been really focused on that journey from start to finish from a digital perspective. And then I've moved into the operational and strategic space. So writing up our future strategy for outpatients at the trust. And looking at our overall journey throughout the whole hospital and transforming our services, which are very much decentralized outpatient service. So looking at how we can put some central structures within the trust.
Very good. Thank you, Alex. John.
Thanks, Shane. I'm a consultant in oral medicine at Birmingham Dental Hospital, and for the wider trust, I'm a Chief Clinical Information Officer. I started out in outpatient transformation, basically putting in remote consultation as a response to the pandemic, which then led on to me being clinical lead for digital inclusion and remote consultation for the integrated care system in Birmingham and Solihull. As well as being clinical lead for the NHS England Remote Consultation Improvement Toolkit, which is now live, and I would encourage people to have a look at that. And I'm now focusing on system-facing digital platforms and digital solutions to support outpatient transformation more generally, so things like PIFU, advice and guidance, etc.
Very good. Thank you, John, and all for joining us. Appreciate you taking your time to share some insights. So as I said, I'm Shane and a concept advisor at Space Store Healthcare. So my main role is working with the likes of NHS trusts on helping them on the outpatient transformation and where we can help with our products to help increase outputs of virtual consultations using our space-defined and modular furniture products. And also joining me today is my colleague Alex. If you want to introduce yourself, Alex.
Sure, thanks Shane, and good to be on the call today. Thanks again to our panelists. Looking forward to hearing insights and experiences and what tos and maybe what not tos. Certainly the experiences and what people have tried in the past is always valuable learnings for all of us. So my role at Space Store is similarly to Shane, workplace concept advisory, mainly working with some of our corporate clients. So a lot of my time spent with some of the bigger blue chip organizations who themselves are going through often some kind of business transformation. Usually it's right now, usually one of the big topics is the whole hybrid workplace experience and how these organizations, you know, the Googles, the JP Morgans, the large corporations of this world can create the best employee experience. And the Space Store product family fits that need in a very similar way that it fits the need within some of the healthcare trusts that we've worked with, which is around providing individual spaces, whether that's for video calls, for phone calls, but acoustic privacy of some sort. So looking forward to hearing the conversation and taking part today. Thanks, Shane.
Good, thank you, Alex. So I thought to kick off and get started, maybe if between the panel would just come up with some of the key challenges we've been facing over the past year or two, and then we can maybe start look at some of the solutions and experiences you've had in tackling those. So I don't know, Scott, if you want to kick off, or someone.
Yeah, sure. I can kick off. I think at the moment the challenges we face is that we've got a very large backlog of patients that need to be seen post-pandemic, and we don't have a workforce that matches that backlog in terms of, there are workforce issues in the NHS across the field, and our ability to then see those patients is a bit limited by the fact that we don't just have this on tap workforce that we can increase, and we've got problems with recruitment and retention in many areas of the NHS. So that's driven the kind of agenda of trying to see patients in a different way or trying to deliver their care in a different way, which then poses the issue around transforming our pathways for our patients with the right kind of engagement, and having people being able to engage in that process and have the headspace to do that. And actually one of the challenges that I face that week in, week out when trying to do transformation in this arena is actually the clinicians and the teams having the headspace to be able to do it when really they're being pushed very hard from a number of different quarters around actually delivering extra capacity to try and deal with the backlogs and get our 52-week waits, say, down, which is one of the big emphases at the moment that's hitting the NHS across the piece. So I suppose one of my things is around workforce, and secondly, the other thing is around the plethora of digital solutions that are out there, and the infrastructure in most NHS trusts to actually deliver that. And I think we've got a key time going forward around how people are going to actually decide which IT solutions will best suit them in terms of how to deliver their different pathways and implementing that, but also have they got the right infrastructure in their digital services to actually support those digital strategies or those digital platforms that they're trying to then deliver to help the patient experience and communicate with patients more effectively. So I think that's I'll put that out there as a starter for 10.
Good, thank you. Yeah, appreciate that, and definitely something we've seen from the work we've done as well. So definitely echo that. Alex and John, feel free to add your comments.
Yeah, I mean, I'd echo what Scott has said. I think the big thing for me at the moment is limited capacity of our teams for change. How do we manage that organisational development? How do you manage engagement with clinical teams when they're already flat out working at the coalface? We have limited resources in terms of finances as well. And actually, if you're going to do some of this stuff, there's a sort of invest to save agenda or at least an invest to increase productivity agenda. And then the other thing that I worry about are the downstream impacts. So some of the stuff that I'm looking at is the digital enablers of outpatient transformation, and a lot of that citizen facing. But what's the downstream impact of that? You know, how's it going to impact in terms of digital inclusion and health literacy? And so that all needs to be considered in the round.
Yeah, and I mean, just to jump in, I mean, I had a part of my role is to go or reach out to all of the organisation and discuss issues with clinical, non-clinical staff across all of outpatients. And one of the things that really crops up is the capacity aspect, but not only in terms of space and being able to book rooms, but also the kind of culture around almost like a tribal aspect of we own this space, we don't own this space. And that might be just our trust because we're not set up that way. But I feel like there's a whole aspect of trying to look at the flow of how rooms are used, how the capacities used effectively, and how we can really maximize that. So that's a major issue that every single person within my trust has brought up with me. And then just to add to the list, I'm sure there's quite a long list we could go through, is about patient communications and the systems we use to do that, and the processes really, really tricky. I received a complaint recently, or I received quite a few complaints, to be honest, about communication since I've started this role, and most of them about the amount of letters that patients get, the amount of text message reminders, having something written on the letter that isn't actually true. So for example, it might say they have an appointment, but because of the referral system's automated message, they don't actually have an appointment. It has to still be manually booked. I've seen some letters tip-X before. So there's different various things. And I think that patient communications, to me, from my operational role, is one of, if not the most important aspect that we need to look at in terms of transforming the way we do that in our trust.
Yeah, the thing I would add to those two comments around workforce is that it's not just the clinical workforce that's also flat out, it's also the administrative teams. And unfortunately, at the moment, they're being asked to book more and more patients because we need to book waiting list initiatives or Super Saturdays or whatever else it is on top of the normal working week, which actually means that they're also at full capacity with little headroom and headspace in them to help with actually what we need from them, which is when we're redesigning some of these pathways, we need input from those sort of teams in order to make it work effectively. And also we need their input in terms of communicating better with patients around, you know, when their appointments are and other aspects around that. So I think there's a little bit of a double whammy here of it's not just the clinical teams, but it's also the administrative teams that are suffering a little bit at the moment, and that's making transformation that bit more challenging.
I totally agree with that. I feel like the non-clinical person in this call, it's all about teamwork and working together. And I think sometimes that gets lost, and the admin staff so important to the whole flow. So I would echo that, definitely. Need to work together really to find out a solution of how we can really transform outpatients.
I'm interested. Maybe it feels to me as a big part of this, along with many other initiatives, I guess we've all been involved in the past, is around the whole change management process. Interested in any insights you can bring, Scott? I was interested in your phone answering. I can't remember the little buzzy catchphrase you has, but that's a similar concept, right? You know, you're changing how people do a particular task or job.
Yeah. I mean, that we call that take ownership when we did it. And our pickup rate at the time was around 30%, and we got it to over 80%, which, you know, I could look back and say what a success that was. I would question it though these days, being a little wiser and older, and perhaps not quite so enthusiastic about that particular figure. What I would say is some of what we did was very basic stuff around trying to make people's lives a bit easier to answer the phone, which I think was a constructive thing to do. Some of the change management we used in that process was about asking people probably to work a bit harder, which actually now when I look at it, that's what we were doing, but in a veiled way, by disguising it as something else. When actually what I would fundamentally look at, and this is one of my things at the moment, is what infrastructure could we have put in place to make it easier for people to deliver that part of their job, or infrastructure in some other part of the pathway which would have helped them to deliver that part of the job where it was really necessary to do it, rather than just doing it where it doesn't. So, for instance, at the moment we're running e-meet and greet, or we're trying to set up e-meet and greet, which is an NHS initiative around ERS referrals and patients getting a notification that their referral has come in from a GP and that they're actually in the system, which currently doesn't really exist in a lot of places, which I think, you know, means that patients get referred into the big black hole of the NHS and, you know, secondary care system, and they don't know that they're in the system. So one, they'll ring their GP to check has that referral actually happened, because they're not sure it has, and two, then they'll start ringing the hospital to find out where they are on the waiting list and how long will it be before they're seen. Now, something as simple as that referral then automatically setting off a contact to that patient to say, we have your referral from your GP. We will see you in next number of weeks. Will hopefully stop all those phone calls around that. Now, that to me is probably a better example of transforming services where you're putting in the infrastructure that actually supports staff to deliver the sort of work they need to do for those patients who may not be able to engage in that process, rather than what I would say we learned from when I did take ownership was, yeah, it's all very well asking people to work a bit harder, but that only works for so long. And then people will start falling off the wagon and then going back to what they're quite used to doing, you know? So that's, I suppose, my plea is when we're looking at these sort of things, let's try and think of what can actually help in the longer term rather than thinking of the short term.
Really interesting. And I'm guessing a big part of it is the person who's driving that program being near enough to the job to be done to understand like the reality of it rather than just the theoretical kind of patient flow.
It is, but you still need to be able to have that view where you can step back and then go, I can see the bigger picture here, and we need to develop something that may work for the whole thing. You know, it's being able to do a bit of both of those things, which is why it's important to have, I think, the different people involved. So from clinician to management to, you know, whatever else clinical teams that might, because that's where you get that richness and diversity of conversation, which will help you come up with better solutions.
I think another thing that we've been looking at in terms of how we overcome some of these challenges is actually just taking a step back and going, well, have we got the basics right? So it's often really appealing to think, oh, well, I'm going to put in a patient portal and that's going to fix everything because patients will be able to change their own appointments and we'll reduce the impact on our bookings teams. And that'll have downstream impacts on the efficiency of our clinics and our capacity and reduce DNAs. And that all sounds wonderful. And then you realise that you don't have a fully implemented EPR. So you do kind of need to look at it and go, have we got the basics right here before you start doing anything fancy? And I think co-design is really important, and you need to do that with your operational staff, your administrative staff, and you need to do that with your frontline clinicians. But you need to do it with your citizens as well. And if you don't get that piece right, then it's not going to be accepted by anyone. And we did a recent piece of engagement work around digital inclusion, and we engaged really broadly with a number of seldom heard communities. And one of the pieces of feedback that we got that really stuck in my head was, oh, well, we answer these sorts of questions all the time, and nobody listens to us. So I think we go out there and we do engage with citizens, but we don't necessarily listen to them. So I think there's something about engaging with the right people, but there's also something about acting on what those people say.
I think the other thing is being seen to act on it. Sometimes you kind of go away and do it, but you don't feed back and say, hey, we heard what you said, we changed A, B, and C as a result.
Yeah, I think that also has an impact on trust as well, because when we did a similar sort of thing to John and his group, where we went and interviewed over 250 patients from different backgrounds around their experience of coming to our hospitals, and asking them what were the barriers to coming and why they didn't come when they didn't come. And one of the key themes was around a little bit around not just communication and transport, which are the classics, but there was an element of trust as well, and having trust in the hospitals to deal with them. But that was partly because we're not doing the listening bit, where we're listening to what they're saying and then going, as you say, go back to them and say, we've heard what you've said and we've responded in a way that, you know, we feel is appropriate. What do you think? And that would build that trust with the community that we're not currently doing, because we tend to work in isolation and think that we know best, and then implement the change and do the change thinking that this is going to be the way forward and everyone's going to accept it, which is a very sort of parental way of looking at it, rather than working with our communities for something that would work better for them.
Yeah, I mean, I wanted to add that so our trust does our own patient portal called My Medical Record, but it's been around for a number of years, probably 12 years. But it kind of organically has grown from having specialist clinical pathways. So the relationship building that system's been built with people that have specific conditions. So, for example, our biggest patient cohort is IBD. But there's that really close relationship. When we've tried to make it a general platform, and we've got, I think, around 180,000 people signed up, but the actual hit rate every month of logging in is only still really relatively low, and still with those patients that are on the specialist clinical pathways, we find it really difficult to engage with them and hear what they want to see from a general system. So, you know, at the moment you can view your appointment, you get your blood results, you get a text message and an email, great. But if we want more engagement and more inclusion, we need to really get patients involved in building that general platform, which we succeeded in the specialist clinical platform, but not that wider picture. So we've been trying to involve patient experience team a bit more. We've been trying to get patients on our panels. We've been talking about getting patients on our outpatient steering board, which is fairly new. So yeah, I think that engagement is really, really key to outpatient transformation. You're listening to, in effect, our patients who in effect are our customers, and we need to be able to really work with them to transform our services for the best of them.
Just going to come in on a comment that Scott made earlier about working in isolation. That's another thing that I've come across. So if you look about the NHS, and actually we're not that good at communicating between trusts, but there are very few things that haven't been tried somewhere. And, you know, there's blueprints out there that we can very easily access and not reinvent the wheel. And I'm a great believer in pinching with pride. You know, it makes it so much easier if you can go and look at what someone else has done. And I completely accept that a sense of place is important and geography is important, and the populations that we serve might be different, but there's huge learning to be had out there. But one of the things that you come across is this whole thing of not invented here. And so I think it's really important not to try and reinvent the wheel, and be quite disciplined about that, and try and pinch off other NHS trusts and outside of the NHS wherever possible. And then the other thing that I think is a potential challenge, but actually something that we need to work to overcome, and there are strategies to overcoming it, is how we work effectively as systems, because we're not just individual provider organisations anymore. We have a responsibility to work together as integrated care systems. And I think one of the things that I've seen as a great advantage of this is, whilst we're still learning how to work effectively together, and how we move money around the system. Previously, primary care and secondary care didn't really talk to each other brilliantly well. And the system is enabling us to talk to each other much more effectively. And I think the ambition would be that we manage patient flows more effectively. We don't move work around the system without acknowledging its impacts on different parts of the system and different providers in the system. And we can streamline care across pathways. And I think it's always interesting when you talk about pathways, especially if you've worked in a big acute provider. I think there's a little bit of reluctance about whether pathways actually work in that context. But for things like chronic disease, I think especially, musculoskeletal diabetes, there are huge opportunities for you to get that right across a regional economy by talking to each other effectively. And actually, digital stuff can really help you to align that.
Just your first point there, John, have you found any kind of platforms or forums or just thinking that kind of sharing between trusts, that, as you say, there's a ton of things being tried and already been tried. Have you found any good methods for kind of sharing that? Because sometimes it's the kind of impromptu, hey, we're doing this, oh, so are we, kind of thing, like the kind of serendipitous crossovers. So go ahead.
So NHS Futures is quite good in that respect. But the way it's partitioned and what you have access to can make it a little bit interesting to navigate. So NHS Futures is good in that respect. There's nothing else really out there that I've come across. I mean, medical Twitter is an interesting place, or medical X as it's called now. So yeah, I'm not sure that I would necessarily go to other forms of social media. But in NHS Futures, there is a lot on there, but it's difficult to navigate.
We just got Katie in the audience who's raised her hand. So, Katie, do you have a question or some thoughts to share?
I need to sort of explain. So, hi, John. You know.
Hi, Katie.
I don't know if you can hear. Can you actually hear me? Because I think I've actually frozen. But does that? Can you?
Yeah, we can hear you. Yeah, we're good.
Okay, lovely. Okay, sorry about that. So I have to explain that I'm actually working on the remote consultation pilot with NHS England. So I've got a real vested interest in all of this. And I'm also a nurse by background. Really just wanted to add some little insights from the pilot that we've now been running for over a year. And we've been working mainly with community specialties, where we've seen some really exciting stuff beginning to be delivered. And I want to flag especially the work that we've done around heart failure and heart failure services, community-based heart failure services. And John, do come in if you want to add to that, but in turning completely transforming the way heart failure patients are being looked after and moving them on to remote consultations, which is great. We've also done some really exciting work around cardiac rehabilitation, patients who are dropping out of their cardiac rehabilitation programs, but through a quick remote consultation are quite quickly being brought back into their gym-based programs. So I think there's some very exciting stuff with the potential for this to be expanded very much more. We have the potential to do some great stuff with gynecology. And we have done some work with the Black Country ICB, which we haven't managed to get off the ground yet, but they've done some fantastic work around working out which particular gynecology subspecialties they think are going to be most suitable for remote consultations. And bearing in mind the huge backlogs that are around gynecology, I think that this is an area where we could really go much further and much faster. So I think my experience of having worked on the remote consultation toolkit pilot is actually it's all about the detail. It's about identifying those specific clinical specialties that are open to the ideas of going for remote consultation. It's that painstaking, nitty-gritty work that you have to do around pathway redesign. I absolutely agree with the fact that it's not just the clinical teams, though obviously if your clinical teams don't come on board, then you're never going to get anything to move forward. But bringing those admin teams in and actually scribing those pathways, so you're making sure that every member of that team is involved in the pathway. And then it's that really difficult stuff around data collection. How do we collect the data? How do we explain that the data is showing that things are moving in a positive direction? And I think we're still struggling with that. So I think we haven't quite nailed that one yet. I think we're only at the beginning of this journey. I really do. And Scott, I remember the Take Ownership initiative because I was a nurse at University Hospitals of Bristol and Weston. So I've come out from that trust, and I'm now with NHSE. So I am really flying the flag big time for remote consultations, and I think the benefits that that there are, I think we just have to keep plugging away, and I think it's a long, hard road, but we're on it now, and we just have to keep going. So thank you very much. I will say no more.
I'll just come in there because thank you for your observations in that. I actually think you raise an interesting point, which is around the metrics that are used to measure success in this arena, and I suppose that the bottom line is bums on seats, of course. But actually, is that really a true reflection of what we're trying to deliver here? Because if actually you've got better patient engagement and the quality of their outcome is better, then actually is that not a better service than just because we saw an extra 10% of patients this month or next month, you know? And I think this does come round to our appetite to actually measure the things that probably are more important to our patients, rather than thinking about this in terms of a volume issue, which yes, it is, because our eyes are all focused on backlogs and the size of the issue, a bit like DNAs, where we have 8 million DNAs every year in the NHS service, but which is a huge waste. But actually, it's the quality of what we're delivering is also the issue. So yeah, I think you raise a good point.
I think Katie has provided a really good example of one of the big challenges and one of the ways that you can try to address it, and that's the sort of organisational development, change management piece. And actually, we managed to do an awful lot in terms of really genuinely transformative work with remote consultation, mainly because we were outsourcing a lot of that OD piece to NHS England, and they were giving us resource to do it because we were piloting the toolkit. But how do you find the resource to do that internally? And I think it's about, you know, working smarter and working out how you can find that resource with already pressed teams, which is a challenge. But I think one of the things that we're trying to achieve with a lot of this work is increasing productivity. And if you manage to increase that productivity, I think that then there is an opportunity to say, well, if you've taken less time to deliver an appointment, say using remote consultation, that time that you get back shouldn't all be spent on seeing more patients. Some of that time should be utilised in doing more outpatient transformation, and so it then becomes a sort of self-fulfilling cycle. Virtuous cycle is the word I'm looking for.
I kind of wanted to jump in now. I mean, virtual consultations is so important, but the whole conversation around what we're focusing on, I've just seen Mark's message, and we should focus on, to be clear, the problem we're trying to fix. And that brought me back to like thinking about the standard of work that we're trying to look at here is like, why are we doing this for? And what really, really frustrates me, and I know obviously we have to do something around the targets, but is like I go to some meetings and it's like, oh, we could move percentage point here, or we could save this now, like DNA's here or this, and they're not focused on what I think is the most important bit, which is the patient quality and the patient service that we offer. And I feel like, for example, that the video consultations, what we've done and what you've just described, really is at that heart of like, well, this is about trying to help the patient to have the best experience, having a remote or virtual consultation where patients before wouldn't be able to come to the hospital for whatever reason. Now they can do it wherever they are. And then if you focus on that and why we're doing it for the patient, the metrics and all of the targets and everything come with it. So then you'll start to see the reduction in DNAs. You'll start to see the increases in patient-initiated follow-up. You'll start to see the backlog come down. So I think it's really important. And when you're looking at this transformational piece, as Mark says there, start with the basics, think about why we're doing it for. And for me, that's about the patient. And sometimes I think we get lost in that because of the pressures we're under, trying to do the day-to-day and having to look at trying to firefight all the time. And I think that was a really good point saying that actually using some of that time that's saved to focus on transformation and the bigger picture is really, really key, rather than just saying, right, we've saved this time, now we can get more and more work. And I think that's the wrong way to do it.
Yeah, we kind of need a bit of time built into everyone's job that recognises that they're contributing to some improvement. And that's missing in lots of jobs. But that's what we're asking people to do all the time.
Definitely. The metrics thing is really interesting, isn't it? Because everyone wants a hard objective measure, but I think a lot of the stuff around outpatient transformation is actually more about narrative, or a minimum sort of a data narrative. It can't all be just about hard figures, and a lot of it's around patient stories and some of those softer, more subjective measures. And I think we need to be more respectful of that if we're going to do this properly. And then Mark's point in the chat, I think, is a really good point. And one of the things that I found is that clinicians work in a particular way. We've been trained in a particular way. We're very risk averse, rightly so, because we shouldn't be putting patients at risk of harm. And a lot of clinicians effectively use their review waiting list almost like a database. You're keeping patients on long reviews for not necessarily the right reasons. It's just keeping them in the right place and so that they can easily access care. And so there are real opportunities in outpatient transformation, things like PIFU and remote consultation, to take clinicians on a journey that actually starts with them having a lot of patients on their follow-up lists and ends with them realising that actually in an effectively run health system with effective primary care, with pathways that work across the system, you don't necessarily need to keep people on your follow-up list, and they can be discharged with confidence. And I actually almost see some of the outpatient transformation that we're doing at the moment, like remote consultation and PIFU, as training wheels to get us to the point where we're much more confident to send patients back out to primary care.
Yeah, you're talking about that building trust with clinicians and teams around the process and the way that it will work. And I think that was one of the things when we were doing PIFU here to increase our PIFU rate. We were lucky enough to have one of the national clinical leads for PIFU at the time from NHS England, and she'd done a lot of work in gynecology and in oncology and gynecology. So an area where typically PIFU is not seen as a particularly useful tool because of the risks associated with recurrence and cancer treatments, etc. But actually she was able to demonstrate some really fundamental improvements in how that service was delivered, better for the patients as well as also for the staff and dealing with their workload, which then could be translated to other clinical teams and they could see how that could work for them. And I think it was a good example of where, that kind of clinical champion bit does work, because it does show to other people, it is possible to do it even in some tricky areas where traditionally our risk aversion tends to take over and make us less inclined to engage with that. So yeah, I think it's definitely something that we need to be thinking about, is how do we inspire that confidence in staff to think new and also to be prepared to take a risk in themselves in terms of doing something a bit different and actually being supported by the organisations and their professional bodies as well.
Yeah, it's like a bit corporate, but risk appetite, isn't it? So what steps can we take that we're actually going to take a risk rather than say, oh no, we're not going to do that because of this. Actually, we should say, well, let's do it, and then let's see what we can actually achieve here. But that's a cultural change, I think, is in mindset, as you mentioned, and that naturally occurs within a hospital setting, as you've said, because of obvious reasons. But yeah, sometimes you need to take that leap to make the ultimate change for the for the future.
Again, just on that point, I think Alex, you mentioned much that using AI is just a fairly big and upcoming tool, and just any insights on how people are starting to use that and implement that?
I mean, who knows where AI is going to go to, but we really have to get into it now. From our perspective, we're going to try and start basic and think about what are the benefits of AI, how can we use it, and a lot of it is around automation and just thinking about how we can make staff's lives easier, and again about patient communication, how could patients communicate and use their tool in a more effective way. I mean, we're starting with our online web page where it's got a manual form. It's got 15 bits of information. The patient has to manually put it in. It then goes to our admin teams. They've got to then manually input everything into our systems again. It's just a real kind of nightmare in terms of just getting information and enter information just to change or even request to change an appointment, where we could start to use AI or chatbots or different technology to really start to automate some of that work and reduce the kind of burden on admin teams, release them to do other work. So then something like a chatbot or AI technology can really help with that to really help in terms of the patient journey and also the staff and the clinical teams as well. So I think it's a journey that we're not quite clear yet, and I don't think anyone really knows where it's going to get to, especially within the NHS. But I think if we could start simple and then really implement something that really just helps the patient and the admin teams and maybe the clinical teams very basically, just with some simple questions, for example, then I think that's something that we will really need to invest in terms of the outpatient journey. And I think some people are scared of it, but again, it's about risk appetite, and I think we need to embrace it, and it's because it's coming, and it's coming. You've seen it in the private sector. We really need to take it forward in the NHS.
I think my only observations around the AI stuff is that I think it'll be very useful, and it's got lots of potential. The things that slightly concern me is have we got good enough quality data already to make the AI work, and the infrastructure to support the AI. And I think that's something we're going to need to work through. And I think it comes back to one of the things we were talking about near the start, is for it to really have an impact, we need to map it into the process and the pathway for the patients to have the added value, and not just bring AI in because it happens to be a smart, shiny new bauble that looks pretty and does something flashy. Actually, how does that then deliver better care or improve the pathway or the process that the patient goes through? So those are my sort of last sort of thoughts on AI, which I'm excited by, but at the same time, I think we've got a little bit of work to do.
I tend to agree with that. I think AI is going to be massively important in health. But I think if you look at the digital maturity of most NHS providers, even sort of GDEs, digital exemplars, I don't think we are in a position to utilize AI effectively at all. And if we run after AI because it's the big shiny new thing and don't continue on our journeys to level up our digital maturity and actually integrate digital healthcare properly into our offer as health provider organisations, it's just going to be another mess because we're going after something that we don't have the foundations to support.
I'd say
Feels a
come
bit-
back to me in 6 months to a year's time, see if I'm still in the job or not.
You will be, don't worry, Alex. I think AI will replace people and especially skilled people. I was interested in what we're saying because it feels like it goes back to Mark's question earlier. We have to be clear, what problem are we trying to fix, and look at it as AI is one of the tools we can use to help fix the problem, rather than chasing AI for AI's sake, just because it's this new shiny thing, right?
Yeah, I think that's right, and I think we're being cautious. I'm always optimistic. I think I see, as you said, I was like, yeah, we've got to do this, but we have to take the right steps. And as you mentioned about digital maturity, I think that's really key, and we need to be careful with what we're trying to do. But I do think we need to try and embrace it in some ways. But it is an unknown at the moment. I think an unknown quantity, but there's clearly measurements and what we've seen case studies from the private sector. There's clearly some benefits that we can learn from around this technology, but it is kind of an unknown from our perspective.
Good. Sorry, just go for it, John.
I was going to come in on Patricia's comment in the chat, and I think I did talk about this earlier about how important it is to work effectively with primary care, and actually the pathway stuff that we're working on in Birmingham and Solihull is being directed by the needs of primary care. So I absolutely agree that primary care should be the place that this starts, because specialist advice isn't what all patients need. And I think we've almost become the acute sector has become such an important part of the way we deliver health in the UK, that we forget that a lot of people don't actually need to be seen in the acute sector. So I completely agree. But I think you have got 3 people from the acute sector talking in this meeting. But yeah, it's about the conversation, isn't it?
Good. Thanks, John, for working on that comment as well. We have run slightly over time, and appreciate everyone who's still on and the panel for sharing their insights. Has anyone got one quick key takeaway to help our audience for 2024 on transformation?
I was going to say, I think there's a lot, even though we're in a difficult situation or financially, and we really need to try and make change. I mean, this is called revolution rebellion. I mean, I'm not sure we're going to get to either of those stages, but I mean, we need to make changes, and we really need. And I would say that we need to really work together. As the comment just said there, John, you talked about systems. All of us need to work together: patients, staff, clinical staff, admin staff, primary care, secondary care, and really think about the outpatient journey from start to finish. And take those risks to make the change, because outpatients is in a really difficult situation at the moment, and we really need to make changes to affect it in the longer term for the better.
I think my final point would be outward looking. Look to your communities, look to your patients, look to the other organisations that you work with, including primary care, and try and work with them.
Yeah, I was going to say the same thing, Scott. It's all about collaboration, and if you working together is the trick.
Very similar to my final thought, which was communication. I think, Alex, your point earlier, the importance of communication, almost over communication, but also being very careful around how you communicate, whether that's the channel you use or the words that you use.
Definitely, yeah.
Very good. Excellent. Thank you very much. All appreciate your time. Thanks again to our panelists. Very, very good insights shared there, as in the comments, and appreciate you joining. So thanks again and goodbye.